Very good morning, everyone, and I thank the organizers for this opportunity. So I'll be discussing the post-hoc analysis of Lorlatinib with respect to the intracranial efficacy and safety in patients in first-line setting ALK-positive advanced non-small cell lung cancer. It is an analysis of the post-hoc analysis of the CROWN study. So we know that Lorlatinib, it is a potent third-generation inhibitor of ALK, and it has already been shown to have improved progression-free survival compared to Crizotinib with the hazard ratio of 0.28. And we all know that there is very high incidence of brain metastasis in patients with ALK-positive lung cancer patients, and many more patients will develop brain metastasis later. And it has already been seen in the CROWN study that the response rates with the Lorlatinib has been 66% when compared to Crizotinib, which has been only 20%. And even it is one of the rare drugs where we have seen a good percentage of patients having complete response rates to the tune of 61%. However, there were concerns regarding its CNS adverse effects and such as cognitive and mood effects, and as well as safety of Lorlatinib. Hence, this post-hoc exploratory analysis was required to look into the safety and the efficacy of intracranial efficacy of Lorlatinib. So, study design, it is a simple study design, 1:1 randomization of Lorlatinib versus Crizotinib in first-line setting ALK-positive locally advanced or metastatic non-small cell lung cancer patients. Brain metastases were eligible, and there was stratification as per brain metastasis ethnic group, as in, whether patients had received prior radiotherapy or not. And endpoints were progression-free survival, cumulative incidence of CNS progression and non-CNS progression, intracranial response rates, duration of response, and safety. And there were subgroup analysis with respect to the brain metastasis and radiotherapy, and patient-reported outcomes were included for the safety analysis. So at the data cutoff, there were brain metastases in 26 and 27% of the patients in Lorlatinib versus Crizotinib, and prior radiotherapy was received in 21% and 25% of the patients in Lorlatinib and Crizotinib, which were well balanced. So there was significant improvement in PFS, irrespective of the brain metastasis at baseline at 12 months, with Lorlatinib giving up 12-month PFS of 78%, and median PFS was not reached, which was much better and statistically significant than Crizotinib. The effect of radiotherapy, the 12-month PFS rate in patients who had received prior radiotherapy brain metastasis was 88%. And when the radiotherapy was not given for the brain metastasis, then the 12-month PFS was 75%. So the radiotherapy had an advantage. Looking at the cumulative incidence of CNS progression, again, the Lorlatinib was a excellent performer. And with the patients with brain metastasis, the cumulative incidence of CNS progression was 7.4 months. And those who did not have any baseline brain metastasis, only 1% of the patient had progressed at 12 months. So when we compare this data with the LX, so it was quite significantly different, although the numbers of these patients were small. So it can be easily said that the Lorlatinib is highly effective at preventing CNS progression in majority of the patients. When we look at the non-CNS progression, again the Lorlatinib was a clear winner, and the 12-month cumulative incidence of non-CNS progression was also lower, 13% in brain metastasis and 16% in patients with no brain metastasis. Coming to the intracranial complete response rates, excellent intracranial response rates of 61% in Lorlatinib versus 15%. Those patients who had at least one targetable lesion, only 17 patients were there, but again the 71% of the patients had intracranial complete response rates, and median duration of responses were not reached at the data cutoff. And around 83% of the patients had duration of response more than 12 months, and 42% had duration of response more than 18 months. So these are the intracranial responses. So majority of the patients had good intracranial responses, and those who had achieved CR, most of them were on Lorlatinib at the time of evaluation. So this is the data with respect to patients who had both measurable or non-measurable brain metastasis. So out of 23 patients, only 4 patients had end of treatment due to progression. And most of the patients who were on, who had achieved CR, they were on Lorlatinib at the time of data cutoff. And this is the data for patients who had at least one measurable brain lesion. And only one patient had progressed at the time of data cutoff. Coming to the incidence of CNS adverse effects, the Lorlatinib overall incidence of CNS adverse effects was 35% versus 11%. Majority of the side effects were grade 1 only, 62%. Grade 2 were 29% and grade 3 were 10%. There were no grade 4 or grade 5 adverse effects seen. And CNS adverse effects were more in patients who had brain metastasis compared to non-brain metastasis, 42% versus 32%. And radiotherapy also added to the incidence of brain metastasis, 56% versus 34%. Coming to the patient-reported outcomes. So emotional functional scores, they improved over a period of time by cycle 18 and clinically meaningful improvements were observed in patients with or without any CNS adverse effects or mood effects. But when it comes to the cognitive adverse effects, then this was not the case. When we look at the cognitive functional scores, so again the declines were seen in the cognitive function scores, but they were not clinically meaningful. The cognitive functioning score declined by minus 4.85 in patients who had CNS effects, and it declined by minus 6.34 in patients who had cognitive effects. Whereas in patients who had emotional, the mood effects, the similar thing was not seen. So coming on to the management, so more than half of the CNS adverse effects were managed without any intervention. 53% resolved spontaneously. There were 2 treatment discontinuations due to grade 2 and grade 3 confusion, and around 45% of the patient, the adverse effects did not resolve. So probably it can be said about that probably they were either manageable or maybe some kind of additional intervention might have been done, but they were mostly grade 1 only. So coming on to the impact of dose modification on the progression-free survival. So a landmark analysis was done at 16 weeks of PFS. For those patients who had who were dose modified versus those who did not. And there was the 12-month PFS was 84% in both the arms. So there was no difference when the dose was, whether the dose was reduced or not. Then the comparison was done with respect to the relative dose intensity, and the cutoff of 98.6% of RDI was seen. And again, there was no difference between those who had a relative dose intensity of more than 98.6% versus those who had relative dose intensity of less than 98.6% at 16 weeks. So when we compare this data with the other data of LX and ALTA trials, so the PFS was more or less of the same tune. However, the PFS in patients without baseline brain metastasis, so Lorlatinib did significantly better with achieving hazard ratio of 0.32 versus 0.46 and 0.65, and this could be attributed probably to the better intracranial responses, which were significantly higher to the tune of 71%. So to conclude, it is a good drug with improved PFS outcomes, reducing the CNS progression in the first-line advanced ALK positive non-small cell lung cancer. Intracranial responses were durable, and many of the CNS adverse effects they resolved without intervention, and with required mild dose modifications and or concomitant medication, and it can be the preferred first-line drug in patients with ALK positive non-small cell lung cancer. Thank you.